Good morning, everyone, or good afternoon. I'm Robert Stiles with the Heartland Health Resource Center. We're really pleased to have you here today in our ongoing series with Rochelle Marting to discuss today's topic, Medicare Management Services. Medicare Care Management Services. Rochelle, I'll let you do your introductions and explanation of everything, and glad to have everyone here again today.
All right, great. Thank you so much, Robert. I know we were going to talk about the session next week coming up too on the proposed physician fee schedule, and I'll mention this again at the end of the session, but hopefully you'll join that session. There's a lot of new information that's very technical that has come out in the proposal for the Medicare physician fee schedule that would begin January 1st of 2022. So I hope that you'll join us for that session also. Our topic for today is care management services for Medicare, and care management services is a subset, kind of a category of benefits, similar to the way telehealth is a category of benefits under the Medicare program. So I'll talk about what care management, that umbrella kind of term is, and define that, as well as a subset of care management called designated care management and what that means. And then we're going to take a deep dive into a few of the care management services, care plan oversight, transitional care management when a patient's moving from an acute care setting to other care settings back home or to long-term care, chronic and complex chronic care management, and two types of behavioral health or psychiatric collaborative care programs. And then at the end, I'll show you a list of resources that are just excellent fact sheets and FAQs if you want more information on some of these services, if you're already providing them or if you're interested in providing them in the future. So with that, I'll start right in with what care management services are. I'm going to use this term care management to refer to a really broad umbrella term of individual services that are paid for under Medicare. And care management, for the most part, these are not telehealth services. However, they are delivered absent an in-person face-to-face visit between a provider and patient in most instances. So the majority of the care management services that we're talking about involve managing a patient's condition or conditions or treatment plan in between a face-to-face encounter with the patient. They are, exactly like it says, care management and supportive services. Most of these are designed to be provided by clinical staff. And as a reminder, that term clinical staff has a technical definition from Medicare and within the CPT book. And it's generally used to refer to professionals who are clinically trained, but who are not qualified to bill for services independently. So clinical staff would be LPNs, registered nurses, but it's not referring to physicians, nurse practitioners, physician assistants, clinical nurse specialists. So these care management services, for the most part, are designed to be delivered primarily by clinical staff under the direction or under the supervision of physicians and other qualified healthcare professionals. They can be personally provided by the physician, by a nurse practitioner, by a PA, but most of these, the codes that we're going to look at, are not valued as if they were personally performed by the physician or qualified healthcare professional. So it may not financially make sense to have that kind of model in most instances. Most of the care management services, at least at the beginning of the process, involve creating, implementing, revising, and then monitoring the patient's care plan, coordinating the care between or among professionals and different agencies or community support services that the patient's using, and then educating the patient or the patient's caregivers about the patient's condition, about the patient's treatment plan, about the patient's prognosis. And then we've got the provider or a qualified healthcare professional like a nurse practitioner or a physician assistant who is generally directing or overseeing the management and coordinating the service. And this includes medical conditions, psychosocial needs, activities of daily living. It's really a comprehensive view of the patient's medical and psychosocial needs. Now, many of the services that we're going to look at involving care management refer to establishing, implementing, revising, or monitoring a care plan, right? That makes sense. And several of these will refer to a comprehensive plan of care. Well, like a lot of services and a lot of terms that we're dealing with, that is a defined term by Medicare and within the CPT book. And the rules say that a typical comprehensive plan of care will include these different elements. So some of these may not be applicable to all patients. You can certainly include more than what is listed here, but generally Medicare and payers that also reimburse for care management services that require a comprehensive plan of care are going to expect to see the patient's problem list. Okay, we're probably documenting that already. Expected outcome of implementing and monitoring the plan of care, prognosis for the patient, measurable treatment goals. Where are we trying to get from point A to point B by managing the patient's care plan? It'll include a cognitive assessment because remember, these care management services are designed to be comprehensive and address medical and psychosocial needs, functional assessments, symptom management, the different interventions, the different types of services, the different disciplines that the patient needs, whether that's therapy, speech therapy, OT, rehab, behavioral health, medications, etc. An environmental evaluation, what are those psychosocial factors that may impact the patient's condition and compliance with the treatment plan and progress towards those measurable treatment goals and expected outcomes. An assessment of the patient's caregivers, if any. Interaction and coordination with outside resources, if that's applicable. And then a summary or identification of the patient's advanced directives. So then, in addition to a comprehensive plan of care, Medicare and the CPT book outline specific capabilities that providers and practices need to have in place to qualify for providing and billing and being paid for care management services. So the first of those is that the patient has 24/7 access to healthcare providers or clinical staff. There's a couple of things I want to point out in that requirement. 24/7, of course, is one, but the access does not have to be to that patient's personal physician or qualified healthcare provider, but they have to have access to a physician, qualified healthcare professional, or clinical staff. And the last piece of that requirement, the clinical staff, remember, does not have to be a physician, an MD, a DO, a nurse practitioner, or a PA. It could be 24 access to nurse on-call services who can triage the patient. And it doesn't necessarily have to be an employee of the practice. We just want to make sure the patient can get a hold of someone with clinical training 24/7 and have that triage or referral capability. Continuity of care from the patient with a regular or consistent healthcare professional, someone that they can regularly see and get appointments with, that the patient's not bouncing around among different professionals in the practice. The practice has to have the ability to provide timely access to the patient after an emergency department visit or a discharge from a facility. Facility may be acute care facility, it may be a skilled nursing facility, but we have to be able to see the patient timely. Now, timely is not defined by Medicare or defined by the CPT book. But we're going to look at a group of care management services called transitional care management, and they're designed for almost the exact situation that's described by this third bullet point, where a patient is discharged from a facility and we're managing that transition. And in those codes, it refers to a face-to-face visit within either 7 to 14 days, depending on the complexity of the patient's condition. So using that as kind of a benchmark or guide, I would suggest that timely access here following discharge from a facility may reasonably be somewhere between 7 to 14 days of that discharge. The practice is using an electronic health record. This is true even if your practice doesn't participate in MIPS, what used to be the Meaningful Use Program, and those incentive payments. To bill for care management services, you have to be using an electronic health record. You don't necessarily have to be meeting all the MIPS or meaningful use requirements, but you have to have an EHR that you're documenting your services in. You're using a standard method to identify patients who may require or benefit from care management services. That does not mean that all patients who need care management or would benefit from care management have to participate. But this could be a method such as running a report in your electronic record system or your billing system of patients that have 2 chronic conditions, and maybe you define what those conditions are. Maybe we want to start with diabetes or hypertension or asthma or COPD, but you have a standard method and a way to consistently identify patients who need or would benefit from the services. And then once those patients are identified, you have a process so that those identified patients can start receiving their care management services in a timely manner. Within your practice, Medicare and CPT would require that you're documenting these services in a standard form and format so that it looks the same across all patients and all providers in your practice that are receiving care management service. It makes it easier for providers who are collaborating in your practice to identify where these different elements of care management are being provided and documented. You have the ability to engage with and educate patients, the ability to coordinate care. We've got the billing provider, the provider whose name is going on the care management services when they're billed, is overseeing the care team, of course, and then clinical integration among the team members who are helping manage the patient's care and conditions. So this is slide number 3 of requirements and restrictions for the care management category. So as you can see, there are a lot of kind of technical aspects of this before you're rolling out a care management program that you're going to be billing for to make sure we're checking these boxes and we've got all of these requirements covered. These are some technical billing requirements. So in order to bill Medicare for care management services, first of all, we're typically going to have, these are going to be established patients for the most part. And Medicare requires that any patient who is a new patient must have an initiating face-to-face visit, which could be by telehealth. That face-to-face component could be by telehealth for all new patients or patients who have not been seen in the previous year. So a new patient, the definition of that by Medicare and CPT is a patient who has not seen that exact provider or another provider of the exact same specialty and subspecialty in the same group practice or the same tax ID within the last 3 years. So any new patient has to have a face-to-face initiating visit before you can begin providing care management services and billing for care management services. I'll put an asterisk on this also, that in the proposed 2022 physician fee schedule, Medicare is also looking at redefining how they what they consider to be a group practice. Right now, we typically go by tax ID. But if you think of a system like, I'll use the University of Kansas Hospital and Health System, the tax ID for physician practices may constitute clinics located all over the Kansas City metro area, right? And Medicare is trying to, they're examining whether that's the right way to define a group practice, or if they may want to make it more restricted to an individual clinic setting. So with that in mind, we'll keep a lookout for whether Medicare makes any changes to that definition for next year that might then affect who is considered a new patient that may need this initiating visit. Or this could be established patients, so they have been seen by a provider or another provider of the same specialty in the last 3 years, but they have not been seen with a face-to-face service, which can include telehealth, in the last 1 year. And if that's the case, we need an initiating visit to get started with the care management program. So what qualifies as initiating visit or initiating types of service? They have to be face-to-face, which could be face-to-face via telehealth. It can be an evaluation and management service like an office visit. It could be a hospital visit that's been provided face-to-face. It could be the Welcome to Medicare exam, the initial, what's that abbreviation? Initial preventive physical exam, which is a huge misnomer because there's actually not much of a physical exam component to it at all. But that Welcome to Medicare visit could qualify as the initiating visit for care management. Initial and subsequent annual wellness visits can be considered the initiating visit. And then we'll talk about transitional care management again in just a moment, but with transitional care management and patients that are coming out of a facility setting or an acute stay that we're billing for managing that transition out of the facility, there is a face-to-face visit as part of those services, and that can qualify as the initiating visit to begin a care management program with the patient. None of the services that fall under this care management category are considered preventive services under Medicare, which means there's cost sharing that applies. And that can be confusing for patients because these services, again, for the most part, are not face-to-face. They're happening behind the scenes. They're happening in between in-person or face-to-face or telehealth services. So when a patient gets a bill for a care management service and they haven't seen the provider that month, that could be confusing or problematic. So Medicare requires that we get consent from the patient before enrolling them and putting them into our care management patient list and providing these services. That can be in writing. It can be a written consent form that the patient signs, but it doesn't have to be, especially right now if your initiating visit is done via telehealth. That can be a verbal consent, but you have to make sure you're documenting the consent in the record to show that the patient was made aware that cost sharing applies and what the services are, and they agreed to proceed and have the care management services provided. And because there's cost sharing and because we can't force the patient to undergo any services or incur these financial responsibilities, the patient can revoke his or her consent at any time. And when that happens, we need to document the date of revocation. And when that occurs in the middle of a calendar month, because a lot of these services are reported over the course of a calendar month, then we have to look within that calendar month to see if we've met the requirements to bill the services. And if we have, we could still bill them for that calendar month, but the revocation would become effective for the next calendar month or the next reporting period. Because these services describe care over a period of time, for the most part, these are describing care over a calendar month. The date of service that we report when we're actually billing for care management services is typically when we've met the requirements to bill for a particular code. So when we've provided 20 minutes or 60 minutes or the required 70 minutes, depending on what the service is in a calendar month, that day that we meet the requirements could be the date of service that we report. Alternatively, to make it easy, you could just use the last day of the calendar month when you're identifying the date of service. I think that method is a little bit easier, and it avoids the risk that you may not have actually met the requirements on a particular date in the middle of a calendar month to be able to provide and bill for and be paid for the services. Transitional care management services that we'll look at again in more detail in just a moment. That's managing the patient's transition from a hospital setting to home or to another care setting or assisted living, wherever the patient has gone after that acute stay. The date of service reflects the date of the face-to-face visit. That's a part of those services. Now, POS, place of service, not what you may be thinking that's abbreviated for, but the place of service on the claim form is where the provider would ordinarily have delivered face-to-face services. So for the most part, that's probably going to be place of service 11 if you're a regular clinic or office visit setting. These codes also have facility rates and non-facility rates. So if you're a provider-based or facility-based clinic, that could also be place of service 22 that represents an outpatient place of service. Some of these services can be provided and billed by RHCs and FQHCs. So we may have a unique place of service for them as well. Okay, and then there's within these this umbrella category of care management, there's a subset called designated care management services. And I'll show you a list of what that means in just a moment. But those services that are identified as designated care management services can be provided under a broader general level of supervision, which means that the healthcare professional, the physician, the nurse practitioner, the PA, who is overseeing, right, the patient's care management, who's billing for the service, is generally supervising and responsible for the care. It does not mean and does not require that that physician or PA or nurse practitioner and the clinical staff who are providing the care management services be located in the same place at the same time that the clinical staff is managing the patient's care. So we're going to look at that in just a moment. To give you an idea of the kind of categories of care management services, this is care plan oversight. We'll look at those codes in just a moment. Monthly end-stage renal disease, not one that I'm going to cover this afternoon, but certainly one if you've got any questions, I'm happy to answer those. We will look at transitional care management, chronic care management, complex chronic care management, behavioral health integration, and psychiatric collaborative care. We also had a session, gosh, I'm losing track of what month it was now, on remote patient monitoring, remote physiologic monitoring. You see that down here as a care management service. So if you're interested in those, I'd encourage you to go back and look at the recording for that session also. And then designated care management services, those that can be provided under general supervision as opposed to direct supervision, include remote patient monitoring. It includes behavioral health integration, transitional care management, chronic care management, complex chronic care management, psychiatric collaborative care. So most of the services that we're talking about this afternoon can be provided under general supervision and does not require the supervising physician or healthcare professional that's billing for the service to be in the office suite and immediately available with the clinical staff when the care management services are being provided. So that gives us a lot more flexibility for that clinical staff person to maybe be working remotely or to have a shared resource among different practice locations or among different practices helping manage patients' care plans. So let's dig right into some specific care management services, how to code and bill for these, and some specific requirements. So the first category I want to look at is called care plan oversight. And for home health and hospice care. We typically have a physician who is certifying the need for home health services and certifying the need for hospice services. And the patient, is homebound, or the patient has a condition that we reasonably expect would have a life expectancy of 6 months or less. Right? So we have the certified need for hospice or home health services by a physician. And then there's a care plan that's put together under both of those programs for the patient that's going to be entering the hospice agency or the home health agency. So monitoring or overseeing that care plan is a separately billable service by the healthcare provider. And this is separate from and in addition to other medically necessary visits that the provider may have with the patient, to review labs or to review new complaints or worsening conditions or exacerbations. So one of the things I'd point out is with hospice agencies and home health agencies and the physicians that are providing services to those agencies, I often see that care plan oversight is being done, but it's not being billed in addition to regular evaluation and management services. And it's something that the providers are typically doing as part of the regulatory requirements for both of those programs. So let me start with right here in the middle with the coverage requirements that apply to both of these services. So both home health care plan oversight and hospice care plan oversight require a minimum of 30 minutes of time in a calendar month. Now, if you've been attending several of our previous sessions, you may know that time is kind of a funky thing in coding and billing in that some of the requirements for time require that we pass the midpoint, right? So when it says 30 minutes, sometimes that means we need a minimum of 16 minutes. And sometimes when it says 30 minutes or whatever the time identified is, that's a minimum threshold. Well, for care plan oversight, that 30 minutes is a minimum threshold that we have to meet in a calendar month, which also means that we need to make sure the time is documented every time there are activities related to overseeing the care plan by the provider that's billing for the service. Time needs to be documented and accumulated, and that 30-minute threshold reached before we bill for the services. Also, we have to have a face-to-face visit within 6 months before the care plan oversight services are billed. That's usually going to be a pretty easy one to meet because in general, the provider that's billing for the care plan oversight has seen and evaluated the patient in order to certify the need for home health or hospice care. These are not designated care management services, which means they cannot be provided under general supervision of a physician or non-physician practitioner. That actually makes sense because the way these codes are written and the way the payment is made, these are services personally performed and provided by a physician and or a non-physician practitioner, like an APRN or a PA. So now I'm going to move over to the left and we're going to look at hospice care plan oversight. And hospice care plan oversight can only be provided by a physician, an MD or a DO. And so it can be provided by an MD or DO, not nurse practitioners, not physician assistants, not clinical nurse specialists. And even more so, it has to be the provider who signed the plan of care, who delivers the hospice care plan oversight and bills for care plan oversight. And additionally, the physician providing care plan oversight cannot be the medical director of the hospice agency, cannot be an employee of the hospice, and is not furnishing services under an arrangement with the hospice. So now I'm going to go over to the right side, home health agency care plan oversight. Now, these also can be provided by a physician, but additionally, overseeing a home health care plan can be provided by a nurse practitioner, a physician assistant, or a certified nurse specialist. I put those specific credentials here because you'll see the term non-physician practitioner, but in some instances under Medicare rules, there's a broader definition of non-physician practitioner that would include, sometimes it includes therapists, sometimes it includes midwives, but a subset of non-physician practitioners are specifically called out who can deliver home health agency care plan oversight services. Whether it's a physician or a non-physician practitioner doing home health care plan oversight, that professional cannot have a significant ownership in the home health agency, cannot have a financial relationship with the home health agency, cannot have a contractual relationship with the home health agency. And those are terms that are defined in a lot more detail in the regulations. So certainly if you have any questions about that, reach out to HTRC, and that's something I can give you more details on what constitutes those prohibited relationships. Other requirements, if the care plan oversight is being done by a non-physician practitioner, that nurse practitioner or PA or nurse specialist has to have personally seen and examined the patient prior to providing and billing for care plan oversight. That non-physician practitioner is not functioning as a consultant addressing a single medical condition. This is designed to be the comprehensive multidisciplinary plan of care for the patient. And that practitioner is integrating the care with the physician who signed the patient's plan of care. And that physician that the non-physician practitioner is integrating with are either in the same group practice or they have a collaborative or supervision agreement with one another. And I have group practice in quotes because, again, right now, that typically means they're working under the same tax ID, but I'm going to put an asterisk with that because we may see changes to the way group practice is defined in 2022, depending on what happens with the Medicare physician fee schedule. So when these two codes are being billed—
And Rochelle, we do have a question in the chat that I wanted to get to you.
Sure. Yeah, okay, what's the question?
So is the supervising physician for chronic care management services required to sign the chronic care management note to bill for this service?
Okay, so great question. That's going to jump ahead just a little bit to the chronic care management services, which are different than the care plan oversight that we're talking about here. But my recommendation would be, yes, that we have the billing practitioner, the provider that's supervising chronic care management services that we'll talk about in just a little bit, sign the care plan or documentation of the care that has been provided. That demonstrates that that billing provider has the overall level of supervision and oversight, which is one of the requirements of the care management service. So without that signature, we have to have some way to show that that provider is actively involved in the management of the patient's care. And that signature that they've reviewed, that they've agreed, or made certain changes is a great way to demonstrate that. So for these care plan oversight services, they have to be the only service on the claim. So we're not reporting these in conjunction with other medically necessary evaluation and management services to a patient in hospice or to a home health agency patient. They're billed at the end of the calendar month, not in the interim. The home health agency or the hospice's NPI number have to be reported in Loop 23, if it's an electronic claim, that is the referring provider section if you're looking at a paper 1500 claim form, and we need their NPI as the referring provider in that spot on the claim form to get paid. Okay, so I'm going to talk about the next category of care management services, transitional care management. So I've referenced this a couple of times. This is when the patient is transitioning from an inpatient hospital setting. That could be acute care, that could be a rehab hospital, that could be an LTAC, a long-term acute care hospital, partial hospitalization setting. It could be observation status. It could be skilled nursing facility. to the patient's home or community setting, whether that's a residential home, whether that's a long-term care, independent living, assisted living facility. So they're making that transition from a facility setting to a community setting. And with transitional care management, we're managing the patient's medical and psychosocial needs, requiring moderate or high complexity medical decision making in the process of that transition. Moderate and high complexity decision making are determined in the same way that moderate or high complexity decision making is determined for other evaluation and management services. It has the same definition. And that has changed in 2021. It used to be the kind of three components: the amount of problems that the patient has and whether they were new or established to the examining provider, the amount and complexity of data being reviewed, and a table of risk. That table or that formula that we use to calculate the level of decision making has changed for 2021. So we're going to be using the new decision making tables to determine if a patient meets moderate or high complexity and qualifies for transitional care management. And of course, then the complexity of the decision making as moderate or high has to be documented and supported in the record before we bill for these services. So let's take a look at what the two codes or the two options that we have to report transitional care management involve communication with the patient, okay, after the discharge from the facility. That can be, it could be in person, that could be direct contact, that could be telephone, that could be electronic. We just have to have communication with the patient and or the caregiver, I should say, if the patient's not the primary point of contact. And that has to happen within 2 business days of discharge, right? So if the patient's discharged on a Saturday, that has to happen within 2 business days. So by Tuesday of the patient's discharge. So this first code reflects moderate complexity decision-making and a face-to-face visit within 14 days of discharge. Whereas 99496 is high complexity decision-making, and as a result of being highly complex, the face-to-face visit happens within 7 days of discharge. And here's another kind of complicating factor with these codes. The communication is within 2 business days of discharge, but the 14 and the 7 days after discharge that we have a face-to-face visit are calendar days, not business days, right? So if that same patient is discharged on a Saturday, they would have to be seen by the following Friday for 99496, or then 2 Fridays for 99495 within 7 or 14 calendar days of discharge. So what's happening during transitional care management, the provider that's performing and billing for these services is reviewing the discharge information, looking at any pending or needed diagnostics after discharge. So the discharge summary may say something like the patient needs follow-up EKG, needs a follow-up sleep study, needs speech therapy, etc. Things that could be done on an outpatient basis. And the provider's looking at that and coordinating to schedule those remaining diagnostics or looking at anything that's pending and managing the results of those with the patient. Coordinating with providers who are going to be assuming care after discharge, maybe some new specialists, or reassuming care like primary care providers. This may involve educating the patient about their conditions, any new diagnosis, any psychosocial needs or community resources that may be available, referring the patient to community resources, and helping schedule the patient with any appropriate healthcare providers. With transitional care management, we also have some things happening with clinical staff. So the clinical staff helping in this care transition from a facility setting to a community setting could be talking with the patient about different aspects of their care. The clinical staff may be helping coordinate with those community services that the patient uses or the patient is being referred to use, help with self-management of the patient's condition, activities of daily living, helping medication management, helping with treatment compliance and compliance with medications, helping reconcile the patient's medications, and any access to care or support services that the patient needs. So to have these transitional care management services covered, in addition to all of those requirements, the face-to-face service, so that visit within 7 days or 14 days of the patient's discharge, depending on the medical complexity of the patient, is not separately billable. It's included in and it is paid for as part of the transitional care management. If, however, there is a significant separately identifiable service in addition to transitional care management that is provided, that could be billed separately as long as there is still a transitional care management face-to-face visit as part of these services that you're billing. Reconciling the patient's medications and managing the patient's medications has to occur on or after the date of discharge, but no later than the date of the face-to-face visit that is a part of the transitional care management. So I mentioned we're going to follow CPT definitions and guidelines in calculating the medical decision-making complexity and whether that's moderate or high. Regardless of the number of care providers that are involved with the patient, transitional care management can only be performed and billed once per patient per discharge. The discharge service itself, if it's being provided, the discharge from the hospital and the discharge care management is also being provided by the same professional who would be the billing provider for transitional care management. That discharge day care doesn't count as the face-to-face visit that is needed for transitional care management. And the work and the time for transitional care management begins when the patient is discharged and continues for a 30-day period after the date of discharge. Now, because most of the services for transitional care management are not face-to-face, but they do have a face-to-face component, that one face-to-face visit after discharge, transitional care management services are on the Medicare telehealth list, so that visit within 7 or 14 days of discharge can be done via telehealth. And RHCs and FQHCs can provide transitional care management as a standalone service as well. So now
we had a question. Sorry.
Sure.
Go ahead, Robert.
So Rick Warren asked or says, care almost never begins on the first day of the month. No 2-month cycle management is impractical. Do I misunderstand? And Rick, if you want to weigh in, maybe, sorry if I misread what you said.
Yeah, Robert, can you read that again? I heard the part about care not beginning on the first.
Yeah, care almost never begins on the first day of the month. Month-to-month cycle management is impractical. Is that, he says?
Yeah, so I guess I can agree with that comment that it's very difficult to manage that month-to-month, and you don't have to provide necessarily a full calendar month of services for some of these care management that are reported in a calendar month. But what you do have to meet is the minimum time requirements within a single calendar month. So in just one moment when we get to the chronic care management, I'll show you what those time requirements look like. And even if you start on the 15th of the month, providing chronic care management, as long as you meet the time requirements within that calendar month, you could report the services. But I'll agree with the comment that logistically, it's difficult to track this on a month-to-month basis because, you know, on September 1, the time requirements start over, and we have to again meet the minimum time requirements in the calendar month of September to be able to provide those services. So some kind of flow sheet or that kind of concept is the way that most providers would implement that and track the time although logistically it is very challenging because we're often not providing the full 20 minutes or 60 minutes or 70 minutes at any single point in time. It's over the course of the month, and we have to have all those time increments documented to show that we've reached the minimum time threshold. And Robert, hopefully that answers that question, but if it doesn't, once we're looking at these time requirements, jump in and we can review that again too. So I'm going to switch gears just a little bit, and chronic care management is managing a patient's chronic conditions. And chronic conditions can be any condition. Here are some examples of common chronic conditions that are being managed using these services, but it's any condition that the provider reasonably believes is going to last 12 months or more for the patient and significantly impact the patient's risk of significant morbidity, mortality. They could be conditions that last a lifetime, but 12 or more months is really the key factor there. And chronic care management services, I'm gonna put these into two buckets, and I'm gonna call them regular chronic care and complex chronic care. So right now I'm starting with regular chronic care, which is not necessarily complex, but I'll talk about what that means in just a moment. So again, chronic conditions, anything expected to last a year or more, or for the patient's lifetime, with a significant risk of death, a significant risk of acute exacerbation, a significant risk of decompensation, or a significant risk of functional decline. Now, the standard is that there's a significant risk of some exacerbation, a significant risk of some functional decline, not necessarily a risk of significant decline, if that makes sense. So the placement of the word significant, is important in that definition. This could be hypertension, hyperlipidemia, diabetes, etc. So we're going to look at kind of a sequence of codes here that can be reported for chronic care management services. Now, the first of these, you see a little plus sign at the beginning of this, because this can be, we talked about that initiating visit, right, for new patients or patients who have not been seen in the previous 12 months before we start providing chronic care management. And if during that initiating visit, there is significant assessment of the patient to put a care management program in place above and beyond the work that is described by the visit itself, the E&M service, the wellness visit, etc., then you can add on G0506 on top of that initiating visit code and be paid for both. Of course, you really want to hit on the significant, separately identifiable, comprehensive assessment and care planning that's being done to support this add-on code. Then within a calendar month, we have a couple of options. Now the next two, 99490 and 439, these are designed for clinical staff. So you see clinical staff in bold there. Remember, clinical staff are professionals who have clinical training, but they cannot bill for services on their own. Not a physician, not a nurse practitioner. They could be delivering these services, but financially, these are not valued as if a physician or non-physician practitioner is providing this 20 minutes of time. So this is a nurse, this is LPNs or other clinical staff. The first, let me back up. Chronic care management where the patient has 2 or more chronic conditions. Again, anything that could last 12 months or more. We either establish in the first month or we revise or monitor in subsequent months the patient's care plan to manage those chronic conditions. And it takes at least 20 minutes, that's a minimum threshold of clinical staff time. And it's overseen general supervision by a physician or qualified healthcare professional within a single calendar month. But again, to answer that question, it doesn't have to be, you don't have to provide services the entire calendar month. If this starts on the 15th and you meet the 20-minute requirement within that calendar month, you could still report these services. Now, you may have patients with 15 chronic conditions that are taking significantly more time to manage their chronic conditions in a calendar month. And so we've recently, Medicare added this second add-on code, and you can report each additional 20 minutes of clinical staff time within a calendar month. I'm going to put an asterisk though, there's a maximum of 2 units of 99439 per month. And the reason for that is that when you report the first 20 minutes, 99490, with 2 additional 20-minute increments, 99439 times 2, you have a total of 60 minutes, if I've done my math correctly. If you've reached 60 minutes, your patient probably qualifies for complex chronic care management, a different set of codes. And we're going to take a look at those in just a minute as well. And the very last code on this sheet is for chronic care management. And this one is valued higher because it's designed to capture the work when the physician or the qualified healthcare professional himself or herself is personally providing those chronic care management services and reaches at least 30 minutes of time in a calendar month providing those services.
Rochelle, I've got another question for you.
Okay, I love it. Let's go for it.
Would a pain management doctor be eligible to use those codes?
Okay, great question. And the answer is yes. These are not limited to any particular specialty. They're not limited to family practice, general medicine, pediatrics. So any specialty can provide these services for the chronic conditions within their scope that they're managing for the patient.
Perfect. Thank you.
You're welcome. Okay, so in addition to all those bullet point items we talked about that are generally required for most care management services, for chronic care management, we're going to record the patient's demographics, problems, meds, allergies, using certified EHR technology, whether or not you are participating in the MIPS or meaningful use programs. Okay, your EHR technology, that term, it means it's a certified electronic health record technology as defined December of the preceding year. So most of you are if you're participating in those incentive programs, you've got that requirement met. You're already capturing those demographics and problems as part of those programs. So that may not be anything new or additional. We're creating that comprehensive care plan as part of chronic care management services. It's person-centered, it's electronic, it's based on everything from physical, mental, cognitive, psychosocial, functional, environmental needs. So we're assessing those, we're documenting those, inventorying resources. Essentially, it's that comprehensive care plan that we defined at the beginning of the presentation. The patient gets a copy. It'd be great to have a notation in the documentation to indicate that the patient or the caregiver was given a copy of that care plan, and that it has to be available to any of those other providers or community resources who may be assisting with the patient. Chronic care management is covered for rural health clinics and FQHCs as well, although they have a special code G0511 that they're going to report for chronic care management services. Then for our patients where we get require moderate or high complexity decision making and higher time requirements, there are different codes to describe complex chronic care management. Moderate, high complexity decision making is defined the same way that it is in the CPT book for other evaluation and management services. And once we reach that 60-minute threshold, that's when we want to look at these complex chronic care management codes, because it starts with the first 60 minutes of clinical staff time. And so 60 minutes, again, is a minimum threshold that we would have to reach. Clinical staff, typically not a physician or qualified healthcare professional who bills for services on their own. Now, the adult patient profile and the pediatric patient profile here, those are general. Those are not requirements, but it gives you an idea of what a typical patient may look like. 3 or more meds for an adult, that's probably most patients with 2 or more chronic conditions, right? And they have therapeutic interventions that may be med management, that may be different therapies, that may be specialists' needs, etc. Okay, now I'm going to talk about two complementary behavioral health care management services. One's called behavioral health integration. So this is sort of I think it's synonymous to the regular chronic care management, but it's specific to behavioral health needs. And then the next one is psychiatric collaborative care, which I think of as sort of synonymous to complex chronic care, but it's the mental and behavioral health equivalent. So behavioral health integration is taking the treating or the billing provider, the patient, and clinical staff, and they're collaborating together to manage a patient's behavioral health condition. I've highlighted on this slide the certified nurse midwife, because when we think back to care plan oversight, when I mentioned non-physician practitioner is an APRN, a PA, or a clinical nurse specialist. Those are also included here with the addition of nurse midwives who can be the treating practitioner for these services. Behavioral health integration involves an assessment by the primary care team. That's typically going to be the billing provider. And that's, again, not limited. It says primary care team, but that doesn't have to be a primary care specialty. Whoever is primarily involved with the patient's care and management. And they're going to administer validated rating scales, plan the patient's care for behavioral health conditions, and coordinate care. Billing for these services is not limited to behavioral health providers. In fact, it's often billed by more of a primary care specialty, although it's not limited to primary care specialties. Patients eligible for behavioral health integration can be any patient who's got a mental, behavioral health, or psychiatric condition that the provider thinks would benefit from behavioral health integration. And I'll point out RHCs and FQHCs can also bill for these services using the same general care management code G0511. Behavioral health integration is generally going to be performed by clinical staff incident to a provider's services. So under the general supervision, this is a designated care management service. So the clinical staff and the supervising provider do not have to be in the same location when these services are provided. So the code that's used for this, 99484, this describes care management specific to a behavioral health condition. 20 minutes clinical staff time per calendar month. And we've got that initial assessment or a follow-up assessment, depending on whether we're in the first or subsequent months, behavioral health planning, coordinating care, and continuity of care with a member of the care team. And then a step above that, for more complex cases or patients, is psychiatric collaborative care. And the members of these services and these care teams, we see the treating provider, but we also see two others. Behavioral health care manager, which is someone with formal education in behavioral health, like a social worker, like a nurse, like a psychologist, and a psychiatric consultant who is often not an employee of the practice providing the collaborative care. For psychiatric conditions. Now, because we've got these additional staff, a behavioral health care manager and a psychiatric consultant involved, these are more complex. They're valued higher than behavioral health integration services. And here, the behavioral health care manager, who's the nurse or psychologist with behavioral health education and training, they're kind of the quarterback of this team. They communicate to the treating and billing provider. They coordinate with the psychiatric consultant. And the psychiatric consultant's role is to really look at the patient's condition and help with medication management. So that could be like a psychiatrist. And the psychiatric consultant has to have the ability within their scope of practice to prescribe the full range of medications. So it is typically a psychiatrist looking specifically at the patient's behavioral or psychiatric medications and providing that advice back to the behavioral health manager to coordinate with the patient's treating provider. RHCs, FQHCs can also report these services with G0512. And I should mention both G0511, G0512, when reported by the RHC and FQHC, are billed with revenue code 052X, with the X depending on what type of claim it is. And so lastly, and briefly, this is what the psychiatric collaborative care codes look like. We have the very first one, G2212, is for an initial or a subsequent psychiatric collaborative care, the first 30 minutes in a calendar month, right? And then if it's that code was kind of an add-on later, because initially we started with only 99492 that required 70 minutes in a calendar month. And provider feedback says we need something we need to be paid for something less than 70 minutes. So G2214 was created to account for a minimum of 30 minutes of psychiatric collaborative care with the treating provider, behavioral health care manager, and a psychiatric consultant. Then in subsequent months, we have 99493 for 60 minutes in a subsequent month, and any subsequent month or in the initial month that we provide more than 70 or more than 60 minutes of psychiatric collaborative care, we have 99494 for each additional 30 minutes in a calendar month. And then lastly, you see that code for RHCs and FQHCs, a minimum of 70 minutes in the first month or 60 minutes in subsequent calendar months. So I know I've gone, looks like 2 minutes over time. These are great resources to get Medicare fact sheets and FAQs that really get into the weeds on billing for some of these services if you're providing these services or interested in providing them.